What's up, dude?
Well, man, how'd the landing go?
Good, quick one. How's the rotation finishing up with Koski?
Oh, dude, it's awesome. It's a good thing that we go there for 2 months, at least until like you start picking up more deformities, because it's good big case volume.
Yeah, exactly. You're gonna show me the tips and tricks.
Yeah, he's a very efficient system.
Yeah.
It helps. He also has like a fellow and like a PGY 5 or 6 with him.
Mm-hmm. Yeah. Keep things moving.
Yeah.
We did that cervical deformity case last week. It went pretty well.
Yeah, I saw the X-rays for the front back. It looks nice.
Yeah.
I'm still astonished that somehow someone thought it was okay to take out the laminoplasty hardware and just let them go.
Yeah, I was pretty surprised by that as well. But because it shows the natural history of how that goes.
Yeah.
Yeah. But he was doing pretty well, and like the correction was really good.
Did you stopped with pedicle screws up top, right?
Yeah, C2 pedicle screws and then down to T2.
Yeah.
All right. Well, let me text. Let's see, Alpesh and Wellington, see if they're on their way. Otherwise, maybe we'll just wait like 1 or 2 minutes and then probably get started, just for time's sake.
Sounds good.
All righty. I mean, we'll see who else comes on, but you might as well just get started.
Sure. Yeah, it's a relatively quick topic, but
yeah.
Let's just dive right into it.
Yeah.
All right. So this is pretty informal for whoever's on. If you have any questions, just go ahead and ask. So we're basically going to be talking about spine infections. I am going to take more of a clinical spin on this, because I mean the basic science stuff is out there. The literature's out there. We know what bugs these are and how to treat them, and how biofilms are made, and what implant type is more prone to infection, et cetera, et cetera. But this is more from a trainee specific standpoint, because that's the standpoint I know. And a clinical management perspective. What do you do when someone has a suspicion for or a diagnosis of a spine infection? So we'll start with some general information, talk about how these infections kind of get started, and we'll then dive into osteomyelitis and disciitis. I know they're listed separately under like the subtitle heading, but they're very much the same thing. It's a spectrum. And then epidural abscess, as again, that's a feature of an infection, so it's not an independent thing, but it's something that does have a couple of unique aspects that we'll dedicate some specific time to. And then we'll talk about what to do for this. So spine infections, there's how do you get an infection in your spine? There's 3 main routes or possible paths to get that infection. Direct inoculation, kind of uncommon, or you're not really getting, your spine's pretty protected on all sides. Adjacent spread is common, and that's how it spreads. It can spread from other places to your spine to other places. Hematogenous seeding is probably the most common, because your spine has a rich vascular supply. like we talk about here, there's a rich venous plexus. You get retrograde flow from the pelvis with some valveless veins, which makes it a little easier to spread. You can get arterial spread because there's a very dense arteriolar network at the vascularized end plate, and it's a potential landing site for microorganisms. Local spread. So when you have an infection, it can spread pretty aggressively. Like infections they're not respectful. They can blow through any and all sort of landmarks and natural barriers. So a general guideline. This is something that I heard in residency, and it's not, obviously it's not 100% true, but I get it's a little guideline. Infections do not respect the end plate or the disc space. Tumors will. Tumors will generally respect, if they're in the body, they'll respect the disc space. And you definitely, if you put two MRIs next to each other of a tumor versus an infection, you can typically pick which one will be which. And obviously it's not guaranteed, and tumors can invade the disc space and vice versa, but it is something to keep in mind. And this gives you an idea of how aggressively these infections can spread and how they behave. C-spine infections, like we talked about, it can spread to neighboring areas. You can have an infection in the cervical spine that spreads to the mediastinum with disruption of the prevertebral fascia. Obviously, that's a bad situation. It's uncommon, thankfully, but it can happen, and it's just that's because it's neighboring. It's a neighboring potential space, and it's just one layer of fascia in between. And there's no rule that says bacteria can't cross a fascia, like a fascial plane, right? It's uncommon. That's why neck fascia is spreading along a fascial plane in the extremities, but it can happen. And the lumbar spine, infections can track along the psoas caudally all the way down to the pelvis, the groin, the buttock, and they can also spread the opposite way too. There's no rule saying they can't spread against gravity. Meningitis is also a possibility, very uncommon. I don't know if you've seen that from direct spread. Usually an infection, if it invades the epidural space, doesn't typically cause a meningitis. It typically respects the blood-brain barrier, which is pretty robust, but it can. And it's something to keep in mind, especially if you're going down and you're doing a washout, you get a dural tear. When you're doing a washout of an epidural abscess, very high on your differential of any sort of issues post-operatively should be meningitis. And also you should change your antibiotic prophylaxis to include something like ceftriaxone across the blood-brain barrier. Spine infection, I mean, everything's a little different in kids. So with children's infections, spine infections are no different. They have a very rich vascular plexus with the cartilaginous end plates, higher risk of infection to the spine. It's easier for them to get spread to the spine because of the vascular network. So we'll dive right into looking at osteomyelitis / disciitis. What are your risk factors? Who are the folks who are getting these infections? IV drug users are the big one. Orthobullets will test you on that a number of ways. Males have a little bit of a higher risk. Diabetes, obesity, obviously, and it's the same things. Those are all kind of no-brainers. So where do you get these spine infections when it's involving the body of the disc? Most common in the lumbar spine, 50 to 60% of the time. The T-spine is about 30-40% of the time. That number, I mean, there's 12 thoracic vertebrae, so more often than not, it's in the lumbar spine. The T-spine, there's more vertebral bodies and just more space, so that also makes a pretty significant area. And the C-spine is only about 10%. How do these folks present? Well, systemically, they'll have fevers and weight loss, but they don't have to. These are all things that should make you clinically suspicious. They'll present with back or neck pain. And when you have an advanced infection, this is when you start getting ready to pull the trigger for urgent / emergent surgery, is when you have neurologic compromise. Keep in mind the need to evaluate with imaging with contrast if you have a suspicion for infection. If it's effective in C-spine, you can have some specific location-specific presentations. Neck pain and torticollis can present if the infection is in the C-spine. If there's an abscess, you can develop myelopathy, right, from cord compression, or it could be radiculopathy, depending on where the abscess is sitting, where it's having its mass effect. And meningitis, like we talked about, is a direct spread from technically anywhere in the spine if it gets into the meninges and can travel up. So there's a whole constellation of symptoms that you need to keep an eye on. What pathogen? Like we've talked about, we're not going to dive too far into the basic science part of infections, but we'll touch on it here. Pathogen is Staph aureus 50% of the time. After that, epidermidis is the second most common. In IV drug users, you'll get Pseudomonas. Sickle cell patients, you'll get Salmonella. If you have a spread from the GU, so this is like from the pelvis going up, you can start seeing weird things, E. coli and Proteus, and TB has its own. I mean, we don't see that often, but it has its own. Pott's disease is a whole separate thing. So what do you do when you see these folks you're concerned about infection? You want to obviously check their labs. White blood cells are only elevated in about 50% of cases. Again, this goes hand in hand with how systemically ill they are. They're not always going to be floridly septic, right? They could have just a back pain that hasn't really responded, and a mildly elevated white count. ESR and CRP will be elevated. Blood cultures you always want to obtain before you start throwing antibiotics at them, unless they're like septic and absolutely need it, because that'll help. They can help you isolate the pathogen. And like we talked about, a big source of spine infection is hematogenous spread. So if you can get it in the blood culture, it can help you quite a bit. The gold standard is biopsy for pathogen identification. You absolutely need to know what it is that's in there, because that's how you target your antibiotics. Gold standard is always going to be biopsy, CT guided versus open. You can, if you get lucky, you can get something via blood culture, especially if it spread hematogenously, and you can hold the antibiotics unless, like we talked about, they're systemically ill. In terms of antibiotics, all these folks are going to need IV antibiotics for the most part. I can't imagine anyone trying to treat someone who has like a true spine infection with just oral antibiotics. So likely going to go the PICC route, but obviously a little bit of a case-by-case basis. When we're looking at imaging, X-rays, they're obviously slow to show changes, right? This is a case with everything, whether it's bony fusion, bony destruction with the infection. They're going to be slow to change. Chronic changes, you'll see end plate erosion. And if it's pretty significant, you can see deformity secondary to an infection, and disc space collapse. You can also see bony collapse if that's where the infection's really been. Gas in the soft tissues will show up on X-ray. You can see sometimes, depending on where the infection is, you can see a shadow at the psoas. Mediastinal widening, like we talked about, it spreads from the C-spine down to the mediastinum. TB is a pretty classic picture, vertebral body destruction with the preserved disc spaces above and below. This is Pott's disease. It's pretty standard. We don't really see it all that much anymore. I think like last generation used to operate on these and see these folks quite a bit, but I honestly have seen maybe only one case in my 6 years so far. Looking at other modalities of imaging, the technetium-99 scan, it's more useful in kids. We wouldn't really go for this in adults, but you should know that it's sensitive, but it has poor specificity, right? It'll light up because of increased metabolic uptake, but it's not going to tell you what the reason is. Infection is just on your differential, but it is useful in kids. One of the advanced imaging capabilities that we often use is CT scan, really for bone evaluation. It can show some soft tissue shadows, and you can see, it can hint about the possibility of an abscess. Myelogram, you don't want to do it if you're concerned about an abscess, like we talked about. You don't want to be disrupting the meninges when there's a potential of direct inoculation like that, giving someone a meningitis. CT, why do we get a CT if we can't see the abscess so clearly? Because it's way faster, and also you need to get you need to have an appreciation for what the bony alignment and extent of bony destruction is. MRI is obviously the workhorse here. You get it with contrast because that'll better define a collection like an abscess. It'll help differentiate versus degenerative changes. It doesn't really tell you much about tumor versus infection. That's a clinical judgment situation, but it'll at least narrow it down to those two. It's great at identifying epidural involvement. Really, you need it to evaluate the status of the neural elements, and that goes hand in hand with a good physical exam. And the MRI, obviously, high sensitivity, high specificity, both over 95%. So what happens with spinal infection? What are the sequelae that you get from osteomyelitis and disciitis? If it turns into an abscess, you can get neurologic complications with involvement of the canal, mass effect from the abscess. You can eventually get a possible vascular infarct. It's not common, but it's possible. And when you start having fractures or compromised bony integrity, then you have resultant deformities. And I mean, we did a large case with Dr. Koski, like maybe 2-3 weeks ago, about a patient, IV drug user, had who needed a large I think it was a VCR and several osteotomies to correct a great degree of bony destruction that happened from due to an infection. So these things, if left unchecked or gone unrecognized, can cause some serious trouble down the line. Looking specifically at pediatrics, you need to have a high, I mean, I think this goes kind of for everything within pediatrics. You see, have a high clinical suspicion when they have any back or neck pain, right? Or do they have a meningitis? Do they need a spinal tap? Specifically, you should be concerned about an infection affecting the neuroaxis when they're in a flexed spinal posture at rest. If they have a low-grade fever, you can't find a source for it. And if they're not bearing weight, it's not always going to be their extremity. And orthopedics, we're always guilty of trying to assume that. When they're chronically infected, you can the kids will they lay down bone like nobody's business, so they're more prone to showing like an autofusion once an infection resolves. How do we treat osteomyelitis? Systemically, you give them IV antibiotics, broad spectrum until cultures are obtained. You want to hold, like I said, you hold off unless they are truly like septically ill. Then you say, well, whatever, we got to get the antibiotics going because you got to keep them alive. You give them Vanc for gram-positives, third-gen cephalosporins for gram-negatives. So 6 to 12 weeks of IV antibiotics, organism-specific. Bracing is mainly done for pain control in adults. Doesn't serve much of a purpose other than that. When there's no neurologic compromise and you can expect the antibiotics to penetrate the area of infection relatively well, then you can try to go non-operatively with just antibiotics and bracing. You do have a risk of deformity. So if you've got like large bony involvement, so what situations would you consider operating even if you didn't have an abscess? Say you've got the equivalent of a burst fracture. You've got really bad infection affecting the vertebral body. There's resultant deformity, and that's pushing the bone out into the canal. That's another situation where you could say, yeah, sure, the antibiotics might eventually treat the infection, but you're going to have resultant issues that you might as well address all at the same time. So abscess is not the only reason that you take someone to the operating room. Bracing also does not completely prevent risk of deformity. So it's something that we do for pain control in adults. What are the indications for a surgical intervention? Clinically, if they have a neurologic compromise, I mean, if it's chronic, then whatever, but especially if it's an evolving neurologic compromise, taken to the operating room. On imaging, if they have an abscess, then for a couple of reasons, for the mass effect in the canal stenosis and the fact that antibiotics don't really penetrate, you want to take them back to the operating room. Cervical spine, generally, they're a little more aggressive about going after it. There's a high risk, there's not much room for the cord and a high risk of cord injury or cord compromise. So folks will tend to pursue that a little more aggressively. If there's a progressive deformity or instability on imaging, then those are further reasons taken to the operating room. All right, let's talk a little bit about epidural abscesses. They are commonly secondary to osteomyelitis, but really especially associated with IV drug use. What is an abscess? This is just basic science. It's a collection of purulent material, cellular debris with bacterial load, and it causes mass effect. That's the real problem with it, right? It's a collection in a place that there isn't much room for anything. It's concerning if it's in the epidural space. It'll cause canal stenosis and neurologic compromise due to the pressure on the neural elements. Like we talked about, poor response to antibiotics. So it's very difficult to treat these with just IV antibiotics. Unless you're in, the lumbar spine, there's some conversations about giving that a chance with IV antibiotics if they're completely neurologically intact, because we've seen enough MRIs, right? We know that when you're just looking at the nerve roots down there after the cord, you have a little more room to play. You can watch things. You can take a flyer and give them antibiotics. But we've got an abscess collection somewhere else where at the cord level, different conversation. So what does an epidural abscess look like on MRI? It'll have a ring enhancing lesion. This is something I don't know how the ED hasn't really kind of caught on. You MRI the entire spine, CTL, Why? Because there's a possibility of skip lesions. So if you've got an abscess in the lumbar spine, image the rest. That should be your reflex. If you're trying to manage this conservatively, it's not commonly done. It has to be under very specific. If it meets specific criteria, then you can consider going non-operatively. If they do have neurologic compromise, it's not progressive and it's chronic, not greater longer than 48 hours, then your potential for recovery drops. So you no longer have to take them to the operating room just for that neurologic compromise. If they're a poor surgical candidate, obviously you need to weigh that and have that conversation with preoperative evaluation and anesthesia. And if there's no neurodeficit, like we talked about, if it's in the lumbar spine, you can, even if it has a defined abscess, you can try to treat it non-operatively. But when you're at cord level, I think it's a much shorter lever to throw, taking that to the operating room. This is interesting. The one study specifically focused on what patient characteristics when they have an epidural abscess, what's associated with a failure of conservative care. And these were big findings: CRP greater than 115, positive blood culture, age greater than 65, and if the pathogen is MRSA, they are more likely to fail conservative management. So basically, if you got one of these four, take them to the operating room or have a little bit of a lower threshold to just wash it out. We're going to quickly kind of dive into surgery. What is that? What's involved? So basically, I kind of broke it down into two parts here. First part is the takeout part. So you have an infection, you likely with a collection, an abscess if you're taking them back to the operating room. So the primary goal is to take out the infection. So take out the bone that's infected, that's not going to heal. Take out the abscess itself. Take out the phlegmon if it's been there for a while. Whatever tissue there is, that may cause trouble down the line. You decompress. You get the bone out of the way so you can safely access it. You debulk and excise what you can. You want to, if you have to, you don't have to start doing like frozen path and look for margins, because you just need to debulk it enough to the point where the antibiotics will be able to do their job. Corpectomy, if it's a big time involving the vertebral body, then you got to take out the body itself, and you can go anterior, lateral, costal transversectomy, however you need to do to get to the vertebral body. And like I said, step one is take the stuff out. Step two is reconstruct, right? You can't just lop it out and let the spine collapse. You have to reconstruct it. Stabilization, deformity correction, if it's a chronic thing, the workhorse is going to be going posterior and fusing them if you have to take down facets and destabilize the spine. If it's a very unique situation, local abscess, you can get away with just taking the lamina down, and some of the facet, you can argue that you could get away without fusing it, but it's most likely going to be going down the fusion route. You can, in terms of what to do to fill the space when you do something like a corpectomy, cage or a structural autograft is the gold standard for infections. I take a trigorgal piece of iliac crest, I think is the best way to go. If you're going to put a cage, try to use titanium. The goals of surgical intervention: get to the OR early if they have any progressive neurologic signs. Right? Rapidly addressing neurologic decline gives them the best chance at recovery. And you go where the money is. You go for the abscess. There's no being cute. There's no working around anything. If there's an infection in the vertebral body, you go get it. If there's an abscess ventral to the cord, you go around. You don't just try to decompress posteriorly. You go around. You get to the abscess. You clean it out, and always give them IV antibiotics. With pediatrics, you don't have to be as aggressive with surgery. IV antibiotics and bracing, there's a number of studies that show that is actually it provides fairly good outcomes, and that's because the IV antibiotics have a better likelihood of penetrating due to the rich vascular supply, and the bracing works better in kids. With POTS disease, TB, your goal is to debride and debulk, and then specifically posterior decompression, anterior column reconstruction, because you have to address the vertebral body collapse, and then right is the antibiotic cocktail that these folks are typically put on. That's it. That's kind of all I got. So it's I think the basic tenets, what you need to really pay attention to is when you have a suspicion for infection, image the whole spine. Get blood cultures. At that point, you can kind of evaluate, do I need to put them on antibiotics right away? When you look at your imaging, you need to compare imaging, goes hand in hand with your exam. Is there no neurologic issue? Do I need to take him to the operating room, or is it something I can manage with observation and IV antibiotics? Also, something to keep in mind, if you do put them on IV antibiotics and you're trying to manage this non-operatively, it's not just set it and forget it. These people can develop neurologic compromise down the line. And if you're not looking, the medicine team or the ID consultant is not going to pay attention to that. So these are patients that you still have to keep an eye on, and because they can take a turn for the worse. And if you develop neurologic compromise, even if you've been on IV antibiotics for a while, you could argue to re-image, but if you know where the abscess is, you can go back and wash it out to do what you need to do to decompress and take pressure off the nerve roots.
Man, that was a good overview. I mean, there's really not too much to say about it. Like you mentioned, it's pretty straightforward. Kind of the principles that you talked about, neurologic compromise first is how I think about it, and then any instability, and then finally, address any deformity later. But for the most part, kind of like what you mentioned, I'll just say anecdotally, in Philly, at least, how the referral system was set up there, all of the spine referrals from kind of the surrounding hospitals, and probably they punted a lot of infection, but we saw tons of infection, tons of cord level abscesses. I can recall at least 4 to 5 cord level kind of abscess cases, and one young girl becoming quadriplegic from a cervical level abscess, and several like older gentlemen too end up getting like paraplegia and stuff. But and this is all acting within, because this isn't like trauma, right? This can be actively evolving. A lot of these people are super sick. They're either what I've seen most are like type 2 diabetics, so really impaired immune system, and they just can't stop this infection, or they have other comorbidities that impair their immune system. So you can literally watch their neuro exam decline over hours, and even with intervening right away in the middle of the night, some of these people are still left with deficits. So it's one of those things that's like kind of scary, and should don't sleep on a cervical epidural abscess, and or thoracic one for that matter. But just interesting lessons though. And yeah, exactly like you said, go where the infection is. If it's, I've seen a few where it's mostly all dorsal, you just do, we did an extensive cervical to thoracic laminectomy, and maybe need to go back another day to do a fusion, but to address the infection first, because that's a big enough surgery. It was all dorsal, that's fine. But some of these have a ventral component. You do an extensive, transpedicular kind of approach to get ventral to the canal, or costotransversectomy, as you mentioned, just to drop your hand enough to get ventral to the cord, and decompress it. So yeah, I mean, the epidural abscess part can come in all sorts of shapes and sizes. Let's see. I think
if
yeah, go ahead.
Issue. Okay. I'm sorry. I was saying, if the abscess is at cord level, even if they don't have any neurodeficits, you pull the trigger.
Yeah, from what I would. Well, it depends on how big it is, the amount of compression, but it's one of those things that it could potentially be treated by IV antibiotics. I think if you do like case literature searches or literature search for IV antibiotic treatment of epidural abscesses, there'll be stuff out there about cord level treatment. But cervical, it's just one of the, depending on how big it is. If it's something very small and benign, maybe, but I would kind of be aggressive about it. The other thing is, yeah, like you mentioned, we used iliac crest autograft for everything, as that's the gold standard infection. And theoretically, if you do like a massive corpectomy later, you can either fill that in with the iliac crest autograft, structural autograft, or corpectomy cage if needed. But I think autograft would be the ideal go-to. Then the other aspect of kind of infections we didn't touch upon, but probably a little bit more straightforward for us is post-surgical infections. Mm-hmm. That's a different beast, but it can be kind of also a big broad topic. And in that situation, it's a lot more of a clinical sort of judgment, right? Because your CRP is going to be elevated for 2 weeks. Your ESR is going to be elevated for 3 to 4 weeks. So if you're in that acute post-surgical time period, it's kind of hard to rely on inflammatory markers. And I go with the fact that a persistent draining wound for several weeks should go back to explore, because you have to presume a deep surgical site infection. And at that point, it's kind of like the joints principles, right? Like it's within 4 weeks, I would thoroughly wash it out, and you get enough of a debridement on the implants, and then hopefully IV antibiotics will take care of the rest. There's questions whether you take out the graft or not, like autograft. Some people will take it out, kind of wash it, put it in betadine, put it back. It's hit or miss. I think from what I've seen, most people just take it out. The main thing for treating spinal infection is stability. So you can't really get rid of the infection unless you actually have a structurally sound spine. Those are a few just kind of tidbits that I was thinking of when you mentioned your talks, but I think pretty much covered the basics of the treatment.
Dr. Divi, quick question on the post-op infection. In some of the trauma literature, we're using like Vancomycin powder now whenever we put hardware in, any of that in the spine. And then also when you do like the big deformity cases and you have a chronic post-op infection, like, 2 months or so, do you just leave the hardware in and pray for fusion and then treat them with IV antibiotics and then plan to come back and take it out once you have a fused construct? Because you can't do like an antibiotics space or anything because you destabilize the spine.
Yeah, you're right. So for like spine, there's no real concept of like a 2-stage kind of surgery. If there's question about the hardware, like it's loose or it's fractured, then you would go ahead and revise it at that index surgery. So you go in, wash everything out, take out the screws, curette out all the holes, do everything you can to clean it, and then put in bigger screws, more stable stuff, and then at that index surgery, and then you get the right ID consult on board with the right IV antibiotic treatment, and then you just kind of pray and hope. The first question you mentioned about the Vanc and Tober powder, I'm not sure about Tober powder, and I think there's just stuff starting to look into that, but Vanc powder, there's been a lot of papers published on it. A lot of the evidence is animal-based, which shows good evidence in that. All the retrospective clinical studies, most of them favor vancomycin administration, which show like, some reduction in like acute kind of surgical site infections, but I think it's equivocal in human data. So it is what you make of it. I think the reason everyone uses it for the most part here, it's cheap and adds another kind of, if you think about it, it's like a bolus of antibiotics that you put in there. And of course, if you put a drain in, it'll slowly elute out of the drain over the course of 5 days. But hey, maybe it's an extra 5 days of stuff in there, local support. But the Tobra powder, that's interesting. What are you guys using that in trauma with?
Basically anywhere that we use Vanc powder, some butler will put Tobra powder in. He says the evidence is coming from shock per his fellowship.
Interesting. I'll have to look into that, because that'd be kind of cool to look at in, spine as well, like big, deep lumbar wounds or posterior cervical too.
Yeah, just tough to get the power of like the gram-negative infections since it's a lot less common.
Yeah, exactly. Yep. All right. Well, I guess today was a short one, but nice topic. Well, I think I'm supposed to be up next week. I'll double check. It's supposed to be on like research design and stuff, so that one might be relatively short as well. But I'll keep you guys posted. I'll ask Freddie to send out an email.
All right. Perfect. Thanks, guys.
All right. See ya.
Thanks,